free webinar. And by the way, I would like to announce you that to announce our friend who joining us today, that we are organizing the 12 African course for young neurosurgeon, sub-Saharan young neurosurgeon for WFNS Rabat Reference Center. And this course will be held in Rabat, virtually, of course, because this nightmare, and we hope that this nightmare will be better in few days, even a few weeks. And this course is we have more than 80 speakers, Fed.
Yes.
I'm speaking under your control, because he's doing everything. And this course, of course, is a special course because we have all the most speakers are international, and Moroccan speakers faculties will be the chairman of every sessions and summarize what happened during the session. So I invite you that join us in this course. Is the 12. It's held between 18 and 19 November. I mean last week. Thank you again for to be among us today. So. Fed, can you continue your?
Yes, our first speaker is Professor Marwan Haris. He's so famous, and he does not need to be introduced by as usual. I will ask Professor Lakhdar Ghnan to introduce Professor Marwan Haris to our participants. And before that, I want to introduce Professor Lakhdar Ghnan to all participants. Professor Lakhdar Ghnan, he is a functional neurosurgeon, well known in Africa, in North Africa, and he is neurosurgeon and professor of neurosurgery at Hospital Salim Zimirli Al Harraj in Algiers, and he is the general secretary of the Algerian Society of Neurosurgery, and he's very active neurosurgeon, especially in functional neurosurgery. And please, Professor Lakhdar Ghnan, will you introduce Professor Marwan Haris? Thank you.
Good evening, everybody. First of all, I would like to thank my friend Professor Al-Abadi Najia, Dr. Fahd Talqawi, Professor Abdel Hakim Lakhdar, to invited me to participate in this webinar for the functional neurosurgery. Professor Marwan Haris, Professor of Neurosurgery, past chair of functional neurosurgery at the National Hospital for Neurology and Neurosurgery, and the University College London, Spiegel and Wyss Award of World Society of Stereotactic and Functional Neurosurgery. Professor Marwan Haris is a reference in the world for the DBS view of this extraordinary results in the treatment of Parkinson's disease. Today, he will talk about ethics of deep brain stimulation.
Thank you very much for your kind introduction. Shall I start now?
Yes, please. Will you share your screen?
Do you see anything?
Not
yet.
Not yet.
No?
It's okay. Yeah, perfect.
Okay, this is pre-recorded. Just tell me if you don't hear well, please. I start now.
Okay.
Okay. I thank the organizers for inviting me to talk about DBS and ethics in a historical perspective. The definition of ethics is moral principles that govern a person's or a group's behavior. We have, of course, medical ethics, but we have also lawyer ethics, politician ethics, journalist ethics, industry ethics, market ethics, war ethics, etc., and neuroethics. This professor from MIT writes that it is a sad misconception of all too many that ethics is merely an academic exercise of philosophers. Rather, our ability to think and act ethically is arguably one of the defining things of what it is to be human. So ethics is the very fundament on which the physician's profession lies. Everybody knows Hippocrates and his oath. You remember mostly primum nil nocere. But do you know Maimonides, Moses ben Maimon, who was a rabbi and a physician from Cordoba, who studied medicine in Fez in Morocco and became eventually the doctor of Saladin. He had also an oath. And there you can read, Almighty God, do not allow thirst for profit to interfere with my profession. In the sufferer, let me only see the human being. Very interesting. Another doctor from the 9th and 10th century was Ishaq ibn Ali al-Ruhawi. He didn't have an oath of ethics. He had a book called Adab al-Tabib, that means ethics of the physician. He was from northeastern Syria in a village called Ruha. His book was the subject of a whole chapter by the American Philosophical Society called Medical Ethics of Medieval Islam, with special reference to al-Ruhawi's practical ethics of the physician. And they stated in this book that as a work on medical ethics, this is a highly interdisciplinary treatise. I will not go through all his book, but I would also say that he invented the peer review process. According to Ray Spear, in this paper, the first documented description of a peer review process is in a book called Ethics of the Physician by Ishaq bin Ali al-Ruhawi of Al-Raha, Syria. Now, medical ethics is the study of moral values and judgments as they apply to medicine. Everybody knows the basics: autonomy, beneficence, non-maleficence, justice, dignity, truthfulness, and honesty. And the World Medical Association had several meetings, the first one being a meeting in Helsinki in 1964 to establish ethical principles for medical research involving human subjects. And this WMA has met several times since then, last time in Brazil in 2013, and amended and added to the ethical principles. So we have now 37 items on medical research and medical care. So the outline of my lecture is about publications on ethics and DBS. When are they published and why? Dogma and myths on ethics in DBS, ethics of publication about DBS, and DBS industry and marketing ethics. I will show that ethical issues in DBS do not only concern psychiatric DBS. The ethical discourse in functional neurosurgery is not new. Multidisciplinarity in functional neurosurgery is not new. Multidisciplinarity per se is not a guarantee against dubious behavior or unethical reporting and publishing. So let's start with the PubMed. The PubMed on November 7 showed 454 results if you write deep brain stimulation and ethics between 1980 and this year. The first paper and only paper that appeared in 1980 is this paper, Indications and Ethical Consideration of Deep Brain Stimulation. This is the paper authored by 3 neurosurgeons, Jean Siegfried, Yves Lazotte, and Robert Sedan. And that was in the era of DBS mainly for pain, but also they say motor movement disorders and behavioral disturbances. 1987 saw the birth of the modern DBS as we know it today by the group in Grenoble, Benabit, Pollack, and others. And 1999 were the first papers, both from Belgium on DBS in psychiatry. One is Van de Valle's paper on DBS for Gilles de la Tourette, and the other is Bart Nutin's paper on DBS for OCD. And between these two papers, during the 12 years between 87 and 99, you cannot find a single publication on DBS and ethics on the PubMed. The publication started in 2002, that is in the era of DBS in psychiatry. So why did the ethical discourse about DBS start only when DBS moved from neurology to psychiatry? Is it so that ethical issues are not relevant to DBS in neurology? The common reasons are the errors of the past, the abuse of the early era, neurosurgeons acting in isolation, lack of multidisciplinarity, all about the early era of psychosurgery. For example, this paper from Tipo Aziz and Kringelbach, DBS avoiding the errors of psychosurgery. Which errors? Errors by whom? They don't say. This paper by ethicist Joe Finn, published in 2006, states, if this generation of neuroscientists and practitioners hope to avoid the abuses of that early era and avoid conflation of neuromodulation with psychosurgery, it is critical that neuromodulation be performed in an interdisciplinary and ethical sound fashion. And then he writes, it is ethically untenable for this work to proceed by neurosurgeons in isolation without psychiatrists determining the diagnosis and suitability of patients for treatment. Now, was this a neurosurgeon in isolation? This was Walter Freeman, American neuropsychiatrist, who started collaborating with a neurosurgeon, James Watts. And eventually, James Watts abandoned him. So Freeman continued to operate himself, and yet it is written by Joe Finn's ethically untenable for this work to proceed by neurosurgeons in isolation. This is another example, a Norwegian psychiatrist, Ernulf Odegaard, who for 34 years was the director of Norway's main mental hospital in Oslo. And this is what he published in the Norwegian Medical Journal. Psychosurgery can be easily performed by the psychiatrist himself with the tools he might have in his pocket, and strangely enough, it may be harmless and effective. 1953. In 1952, the editor of the British Medical Journal wrote, Ethics of Lobotomy. Churchmen have taken part in debates in lay journals, some of them taking the view that the soul is damaged by lobotomy, which should therefore be condemned. And then it says, if the soul can survive death, it can surely survive lobotomy. Again, we are, as neurosurgeons, accused to have done this work in isolation. How about DBS, ethical issues in DBS? This is a paper from Holland. The author says that, for instance, it may remind one of the lobotomies performed by Moniz and Freeman, or of the two-lane electrical stimulation program by Heath. Now, Robert Heath was a professor of psychiatry at Tulane University in New Orleans. And he was one of the pioneers of DBS in psychiatry and behavior. And he was almost obsessed by DBS in the pleasure center, or DBS for pleasure. And probably his most known paper is this one about septal stimulation for the initiation of heterosexual behavior in a homosexual male. There's much more to say about ethics of Heath and his practice. In the year 2000, Bo Meister published this paper about the two-lane electrical brain stimulation program, a historical case study in medical ethics. And the aim was to evaluate the experiments in relation to the historic context in which they occurred. And he writes, the central conclusion of the present review is that the two-lane electrical brain stimulation experiments had neither a scientific nor a clinical justification. the conclusion is that these experiments were dubious and precarious by yesterday's standard in 2000. But already in 1977, Laurie Leitner wrote a chapter about the ethical aspects of psychiatric surgery, in which he criticized Heath, and he wrote, there is no doubt that in his studies, all standards of ethics had been ignored. The ethical responsibility of the editors who accept reports of this kind for publication should also be discussed. In the same paper, he proposed a model of controlled trial, saying that the basic problem of psychosurgery is psychiatric. The initiative considering treatment must come from the psychiatrist. Psychosurgery will remain experimental for years. Its use should be concentrated and restricted to psychosurgical research units having strong and intimate affiliation with scientists from many disciplines. This is still valid today, and this is written by a neurosurgeon. So it was others than neurosurgeons who were acting alone in the past, and neurosurgeons were indeed concerned by ethical issues also in the past. So how about the modern era of psychosurgery and DBS? Was it more honest, more multidisciplinary, more ethical than in the past? This is the first paper about DBS for OCD in the modern era, 1999, the paper by Nutin et al. And in 2002 was the first paper on ethics of DBS, which is written by the same team, first modern ethical guidelines for DBS in OCD. And they had 9 guidelines, but they forgot one. They forgot that all enrolled patients must be accounted for and reported. Because they had 4 patients, they should have been 6. Why that? Because this is a psychiatrist, as Karolinska published in the Swedish Medical Journal, that Swedish patients were first in the world in 1999, and 6 European patients are included in the follow-up. 2 of these are Swedish. The 2 Swedish have been withdrawn in breach of the protocol. They are only mentioned. They are mentioned 11 years later en passant in this paper by Greenberg, who writes only 2 patients operating in Stockholm had no clear benefit. This is breach of the Declaration of Helsinki that negative and inconclusive as well as positive results must be published. This is another paper about a conference to establish scientific and ethical issues related to DBS for disorder of mood, behavior, and thought. This paper had 19 authors, and the conference had 33 participants. Not a single neurosurgeon. There were neurologists, psychiatrists, philosophists, ethicists, etc., but not a single neurosurgeon in a conference about DBS for disorders of mood, behavior, and thought. So it seems that the errors of the past are being repeated by those who scream most about the errors of the past. And for some, multidisciplinarity in practice of neurosurgery for psychiatric illness does not need to include the neurosurgeon. And neurosurgeons often made scapegoats for errors of the past, for unethical behavior, and for lack of multidisciplinarity. Now, how about DBS and ethics in movement disorders? As we said, there was no paper whatsoever between 1987 and 1999 during the DBS for movement disorder era. So the first paper on ethics of DBS in movement disorder was published in 2004 in Dutch, and then translated to English 9 years later in 2013. Now, this is the paper in Dutch by the group of Van der Walle et al. From 2004. And this is the translation in English, authenticity or autonomy. So this is about a patient who, either with the STN DBS on, he was severely manic, but mentally incompetent, or the DBS off, and the patient is totally bedridden, but mentally competent. He could not be managed otherwise with medication. And the patient decided to have his implant permanently left switched on and to spend the rest of his life in a psychiatric clinic in a decent bodily condition, but with a permanent manic state. So by deciding on his well-being while he was mentally competent, the patient sacrificed his mental competence and autonomy. Now, we see that we have a lot of publications about the psychiatric effects of DBS in the STN in Parkinsonian patients. This is a slide courtesy of Jens Folkman showing different side effects, so to speak, of DBS in the STN. This publication from Kulisevsky in Spain about mania, publication about suicide, publication from Salpêtrière about marital or conjugal conflicts. Again from Salpêtrière about marital conflicts. And recently a paper from Germany about the ELSA DBS study. Around half of the patients experience changes in their partnership, mainly a worsening. And we still do this operation. How about publication ethics? So ethics of publication. So first, the lay press can show the glamour of DBS for psychiatry. But this is also the same, it's also the same in the portrayal of lobotomy in the popular press between 1935 and 1960. The press initially used uncritical and sensational reporting styles. Now, in medical publications, one has to abide by publishing negative and inconclusive as well as positive results. So let's look at this publication, the New England Journal of Medicine from 2001 of STN and DBS, STN and pallidal DBS for advanced Parkinson's disease. This was the publication on the basis of which FDA approved DBS in pallidum and STN. So it was 102 bilateral STN DBS patients and 41 bilateral GPI patients. And if you look at table 5 of the adverse event associated with STN and pallidal stimulation, you find only one dysarthria. So one dysarthria in 102 bilateral STN and 0 in 41 bilateral GPI. And otherwise, almost no side effect in all these patients. But then, if you go at the database, of that paper, that was held by Medtronic, and it's written Medtronic Confidential, you have almost 17% of dysarthria in STN and almost 8% in GPI. And not only dysarthria. If you look at confusion, hemorrhage, convulsion, positioning difficulties, if you look at hardware-related issues, all these were much more in the database than in the paper. So this table is a fraud, publication fraud. That was just to give you one example. How about industry and marketing ethics? It is known today and since long time that chronic DBS is not just reversible. And yet, in this brochure of Boston Scientific distributed to patients at Dystonia Europe meeting in April 2018 says, DBS is also reversible. The stimulator and lead can be removed or the entire system can be turned off at any time. We know this is not true. We know that chronic DBS can even be addictive. Once DBS, always DBS. And I, for one, published the first paper in 2001 about hardware failure in Parkinsonian patients with chronic STN DBS is a medical emergency. Eventually, other papers started to appear. This is a paper about failure of chronic pallidal stimulation in dystonic patients, a medical emergency from Oxford. This is a paper from Germany, malignant DBS withdrawal syndrome in patients with Parkinson's disease. The patient died. This is a paper from Kiel about patients who develop infection. 2 of these patients with PD died from DBS withdrawal syndrome. This is a paper from India when the patient could not afford to pay for an emergency replacement of the neurostimulator and ended up in intensive care. 2 patients actually are described here who developed malignant hyperthermia, Parkinsonian crisis. This is a patient from Iran, fatal status dystonicus in tardive dystonia due to depletion of DBS pulse generator. They couldn't afford or couldn't find a new DBS for that patient. And the depletion of the battery is an issue. As we know that battery longevity in general was higher in the older brands. And the Activa PC and SC have about 25% to 40% less battery capacity than the Kinetra or the Soletra, respectively, according to different publications. These are the publications from Kiel, from Berlin, about Kinetra versus PC, from Korea about Soletra versus Activa, SC, from Grenoble, Israel, Clermont-Ferrand, about Kinetra versus PC, in New Jersey publication about Soletra versus SC. All of them show that there was more battery capacity in the Kinetra compared with the newer brand. And infection rate increased almost exponentially at every DBS battery change. And the rechargeable batteries are not suitable for everybody. And this is a trend. This is a trend that was best shown by Apple, which was investigated in France for planned obsolescence, apologized for that, and then was recently fined $27 million for this battery obsolescence. How about the rechargeable battery? It was said to be 9 years, and suddenly it became 15 years. It was an apoptosis, a programmed death of the battery at 9 years that could be extended to 15 years on the same battery by unlocking the chip in the battery implanted in the patient. How about the future of DBS and ethics? The primary purpose of medical research involving human subjects is to understand the causal development effect of diseases and improve preventive, diagnostic, and therapeutic interventions. And yet, in this survey of American neurosurgeons, nearly 50% believed it would be ethical if a safe and effective procedure were developed to provide healthy individuals with surgical memory enhancement. Good luck. This is a paper from Brain by 2 neurologists in Italy. They studied with the functional imaging, moral versus non-moral picture viewing in psychopath and non-psychopath. And they suggested the potential use of DBS to treat antisocial behavior and abnormal morality. This is where the field is going. Is this a déjà vu? We are back to the surgical control of behavior from Robert Heath in Tulane. Are we back to physical control of the mind and toward a psycho-civilized society as written by Delgado in '69? So some conclusions. Ethics is nothing but moral behavior that defines being a human and a physician. Ethics of DBS concerns all kinds of DBS, not only psychiatric DBS. The ethical discourse in DBS should not be hijacked by self-appointed experts whose deeds sometimes contradict their words. Multidisciplinarity in DBS is mandatory, indeed. But multidisciplinarity per se is no guarantee against dubious behavior or unethical reporting. And proper moral and ethical values are not necessarily better or worse within one particular medical profession compared to another. So why stress the moral character of a physician? Well, because rules and guidelines alone are insufficient safeguards. And we have to remember that the definition of ethics, any ethics, is moral principles that govern a person's or a group's behavior. Thank you for your attention.
Thank you, Professor Marwan Haris, for this wonderful presentation. And now I give the floor to Professor Fahd. I think that the discussion is put at the end of the speaker.
Exactly. Thank you, Professor Al-Khdar, and thank you, Professor Marwan, for this standing talk and the discussion by the end of the three talks. We'll have, I'm sure that we have many questions and comments about ethics, the cornerstone of our profession as physicians. Now we move to our second speaker, Professor Ahmed Al-Khani, who will be introduced by Professor Mohammed Shrah. Professor, and before giving the mic to Professor Shrah, I want to introduce him to our participants. Professor Shrah is Professor of Neurophysiology at the Medical School of Marrakech at Qadi Iyad University, and he knows neurosurgery very well and collaborates with us and with the neurosurgeon in Marrakech with the team of Professor Ais Ben Ali for DBS and neuromonitoring, and he is an active member of the Moroccan Society of Neurophysiology. Please, my dear friend, Professor Shrah, will you please introduce our speaker, Professor Ahmed Al-Khani, well-known neurosurgeon from Saudi Arabia. Thank you.
Thank you, Fed. It's a pleasure for me to be here with you for the 33rd Morocco webinar of neurosurgery. I'm pleased to introduce Professor Ahmed Al-Khani, who is a full professor of neurosurgery at King Abdulaziz Medical City in Saudi Arabia, where he serves as the head of neurosurgery department. He's a fellow of the Royal College of Physicians and the Surgeons of Canada, head of education committee, the Pan-Arab Neurosurgical Society, is also the president of the Middle Eastern Society for Stereotactic and Functional Neurosurgery. He received many prizes and awards during his career, like the Best Tutor Award and Distinguished Patient Service Award. He has many publications, more than 40 publications, in fact, with some book chapters. His field of interest is, as you saw in his introduction, it turns around functional neurosurgery and stereotaxis. He will be talking about microvascular decompression for trigeminal neuralgia. It's our pleasure to receive you, Professor. The mic is yours, Professor. We can't hear you. Professor Khani, we can't hear you.
Okay. Thank you very much for the introduction. Once again, thank you very much for the invitation to join for the Moroccan Neurosurgical Society. I'm going to share my screen now. And once again, it's my pleasure. I'd like to introduce the new Center for Neurosciences that King Abdulaziz Medical City is now building. We are still at the 4th level, but maybe in a couple of years, we'll be able to come project and we'll have you all to visit a state-of-art neuroscience tower in our medical city. Once again, it's my honor to be with you in this webinar series for the Moroccan Neurosurgical Society. I would like, of course, to thank Professor Najia Al-Abbadi for her invitation, and my dear friend, Dr. Fahad, for the invitation. So I love the talk of Dr. Marwan Haris when he talked about ethics. The other very important subject to talk about is about pain. And pain is something extremely subjective. And I always love to start with this slide when I talk about pain, because pain is something we don't feel. The patient feels it himself, and it depends on him how he likes to express pain. We will be emotionally involved in his description, but we don't have a real parameters to identify that the patient is really in pain or he's in remission of this painful situation. Maybe the very rare exception is trigeminal neuralgia, because once you have a patient with trigeminal neuralgia, there's no question that he is going to have a severe pain that would affect his lifestyle in a very catastrophic way that may lead even to suicidal attempts, and stopped all his physical activities. The incidence has been worldwide about 400,000, and that means in Morocco we're talking about 1,000 patients per year. Usually unilateral, but bilateral is quite seen, maybe 1 to 2%, and somehow the right side is more than the left. The season and geography is very important. For example, Saudi Arabia is a very hot country, and the amount of trigeminal neuralgia is not that common. However, we have a southern part of Saudi Arabia, which is mountains and it's cold. Let me tell you that at least 70% of what patients that we see are coming from this part of the country because it's a cold part of the country. And if you want to go worldwide, for example, UK have like 6 times or 7 times more common incidence of trigeminal neuralgia as compared to the worldwide number that I'm sure in Saudi are less than this. In this slide, we see the trigeminal nerve going to the medial scape in a very nice high quality thin cut MRI. Sometimes we do see the blood vessel. Sometimes we see that loop of the superior cerebellar artery touching the nerve and causing the trigeminal neuralgia. And we can see that sometimes with an axial MRI with GADO, and in this case, in case of anterior inferior cerebellar artery. However, MRI is mandatory before we go to any medical or surgical treatment because it has been quite widely available. So starting medication without having a neuro images may not be a good idea these days as compared to 15 or 20 years ago. Sometimes you see a huge dolichoectatic basilar artery. Sometimes you see in a patient with demyelination disorders, and this can be presented with trigeminal neuralgia, small tumor like a meningioma in the tentorial, or more rare but very tense trigeminal neuralgia. We see it with patients with epidermoid cyst, and I've seen 3 patients with epidermoid cyst. The worst trigeminal neuralgia I have associated specific pathology in that area. However, if you go to statistics, MRI is not very specific about having to identify the real reason for the trigeminal neuralgia. No, it can eliminate that the patient cannot benefit from microvascular decompression. So it's neither sensitive nor specific. However, we always feel much better when we see some vessel loop around the nerve, and more important, that we rule out another pathology that can be the cause of the trigeminal neuralgia. We always start with medical treatment, and we do have class A evidence that zipine or tegretol does help patients with neuralgia. However, in the market, there are a lot of medication, all with the class C evidence that may be helpful for patient trigeminal neuralgia. In my practice, I start with tegretol, and then I go to Lyrica, and then amitriptyline. But I don't use the whole list of medication that we see on that list for every patient before I call it off for medical treatment. What about surgical intervention? We do have the percutaneous procedure like radiofrequency lesioning, glycerol injection that we don't practice it. I saw it as a junior resident about good 25 years ago. Balloon microcompression is commonly seen in our country, and stereotactic radiosurgery yet to be well established, at least in our country. However, in many centers around the world, it comes sometime high on the list of options for treatment of trigeminal neuralgia. And microvascular decompression remains one of the mainstay or main treatment modality for patients with trigeminal neuralgia. So it's very easy to go with percutaneous radiofrequency rhizotomy, however short-lived temporary relief of the procedure and lasts between 6 months to 2 years. And sometimes, not very rare, that patient may not have recurrence of his symptoms. It's a simple procedure, and all functional neurosurgeons are quite familiar in doing percutaneous rhizotomy. But the topic today is about microvascular decompression, and I cannot say it without mentioning Professor or Dr. Peter Janetta, who is procedure before I was born, 1967. So, and it has been so familiar when anatomical study proved around the years that whenever you have trigeminal neuralgia, there is a vessel loop around it in patients who used to do neurectomy at the past or neurotomy in the past. But Janetta is the first to identify that the vascular loop is the cause of that trigeminal neuralgia, and separating it from the nerve may or will lead to a cure from the symptoms. And in that small diagram, it showed the trigeminal nerve, it showed the ICAP, inferior, and the cerebellar artery anterior trigeminal nerve, and cause the trigeminal neuralgia symptomatology. So we go slowly about how we do that procedure here in our country. Usually in all care hospital, microvascular decompression is done, and it's done by skull-based surgeon as well as with the functional neurosurgeon. So in my practice, I do use supine positioning with support of the ipsilateral side in elderly people, maybe in lateral position with a small C shape, like 2 centimeter craniotomy to identify the exact location for the entrance. And I do always like to see the sigmoid sinus and the transverse sinus and the junction between these two sinuses before opening the dura, to ensure that we have an ultimate access to the CP angle from that direction, and that will make the approach much easier and less retraction on the important neural element. And indeed, the issue is to put a small pad or a telfa between the nerve and the offended vascular structure, like what's seen on this diagram. So just a small photos that I collected from the case that we did last week, going through the same approach where the tent here and the petrous bone on the other side, we're going through the CP angle. We do see a lot of adhesions and arachnoiditis-like picture, especially if the patient has received some form of modality in terms of radiation. For example, this patient had the previous radiosurgery and has a lot of adhesions that we had to go through before we reach to the offended vascular structure. And I do pay a lot of attention to dissect the arachnoid till we identify the nerve from its origin all the way to the Meckel's cave without any adherence to the arachnoid membranes, and that will ensure that there is no traction on the nerve, neither for the dissection and the putting of the telfa, nor for long-term restriction or the vessels here, which is the superior cerebellar artery, and we separate with a piece of telfa, and we found a small loop anterior to the nerve, and we put another one on the side. I belong to the people who like to make sort of a jacket all around the nerve for more than one reason. One of them is to avoid recurrence if the loop moved somehow, so it is stuck to each other and doesn't move away from that angle after we fill the whole space with the CSF and irrigations. Now, many people talk about arterial cause and venous cause, and I'm not sure that this has been proven. Many people call that there is a venous loop or a venous structure that causing the trigeminal neuralgia by pressing on the nerve. I do respect that a lot. I believe that once you don't see the loop of the arterial loop that can cause the trigeminal neuralgia, and once you start to dig around and look for a small venous structure, this maneuver by itself is causing injury to the nerve itself or shaking to the nerve itself, and this by itself will cause relief of the symptoms, but usually temporary, and the patient will come back with his symptoms sometime between 6 to 12 months post-operatively. And this may be one of the reasons why the patient may come back with his symptoms after surgery. Procedure. It is extremely important to know a few things. Number one is the response is very high. So usually you talk about like 80 to 90%, especially if you ruled out other pathology, especially multiple sclerosis, and the response sometimes decline with time. And I do believe that if you were unable to identify the real pathology, or you were unable to separate it from the this is why we do see decline in the percentage of patients who responded very well after microvascular decompression. And this is against the statement saying when you do microvascular decompression, this is a curative procedure forever, and nothing forever, but there's always a small pitfalls in the surgical procedure, which is maybe the reason why a patient would have a recurrence after some time. No question that there is a mortality from microvascular decompression, especially if you don't select your patient very well in terms of anesthesia risk more than anything else, especially patients on anticoagulants or patient who has a major cardiopulmonary risk factors. Injury to the fifth nerve is always there because you are trying to manipulate to put your pillow or your separation between the nerve and the offended vascular loop. Anesthesia dolosa is quite uncommon, and the fleek, something like 2 to 4%. In our practice, maybe it's a bit higher than this, but all of them is being treated very effectively by a lumbar drain for 5 days, and that will take care of the possible CSF leak that we see in some patients. Let me show you a scenario of a patient who had microvascular decompression about 2 years ago in some other institute, and they put the TLFA in place. It is very correct and underneath the nerve, and we have seen the immediate post-op images compared to new images that we did, including CT scan and MRI, and indeed the site and location of that TLFA or Teflon material has still been in the same position when hadn't moved at all. So we were wondering why this patient had a recurrence of his symptoms. So we went and re-explored the site of the trigeminal nerve, and indeed you can see here that you see the trigeminal nerve there, and underneath it is the piece of Teflon that the surgeon has put there. And we looked around everywhere looking for the vessels underneath. We removed that Teflon. We looked all around underneath, no vascular loop, no even venous structure that could be blamed for what's going on. Medications, almost, look what happened now. When we looked dorsal, there is a blood vessels that almost embedded within the trigeminal nerve, not in the normal location where usually you have the arterial loop pressing on the nerve, but rather on the dorsal part of it and almost embedded within the tissue of the trigeminal nerve. And you can see here with the hook trying to remove it from within the tissue of the trigeminal nerve and dissecting it out completely. This tells the importance of looking at the nerve 360 from everywhere, because you can never be sure where is that vascular loop that causing the bad and severe trigeminal pain that the patient is suffering from. And again, we have put our small Teflon underneath the vessel loop and pull it from one side. separating it from the nerve images, separating the vessel loop from the trigeminal nerve, and the patient indeed post-operative did very well with complete resolution of his symptoms. Interesting enough, next day the resident all his medication and he had a seizure. Because of that, you have to be slow in going down with the anti-trigeminal neuralgia medication post-op, because the patient has been on a very high doses for a long time, and you have to be careful from the withdrawal symptoms that may include seizure. Here we are, and here a nice large photo for our pillow underneath the vessel loop and decompressing the trigeminal nerve. And we repeated the CT scan, and this is the old Teflon, and this is the new, what is that? And this is the new one that we put dorsal to the nerve and separating it from the loop, camillocerebellar artery. So let me conclude now. Whenever we have a patient with trigeminal neuralgia, we prefer always to start with simple measures like medications. However, we should not very adamantous about this and delay surgery for a very late stage. If the medication did not help, I guess 6 months to 8 months is good enough time to put that medication is not helpful and go to neurosurgical procedure, putting in mind that other pathology has to be ruled out. And if there is a suggested vascular loop that will make it more likely to go intervention. There are many options to utilize in elderly patients above the age of 70s or patient with comorbidity, especially cardiopulmonary or coagulopathy. We always like to go for a simple percutaneous procedure. Microvascular procedure indeed is the choice. However, we never quote 100% to patient or even 95%, but we quote realistic number of initial improvement. However, over years, 5 to 10 years, this may go down to the level of 70s maybe. Recurrence happen, it does happen in 1 out of 4 patients after 10 years, supported by international literature. Teflon pulled away. If the Teflon itself is the cause of the trigeminal neuralgia, if the patient has a different pathology that has been missed before the surgical intervention, if the patient from previous percutaneous procedure start to have anesthesia dolorosa, and this is why microvascular decompression will not be helpful. So this is in summary what I want to say about trigeminal neuralgia and microvascular decompression for that. And thank you again for inviting me to this talk. And I really enjoyed the previous talk. I'm going to enjoy the next talk also by your speakers. Thank you very much.
Thank you very much, Professor Khani, for this very interesting presentation. Now I will give the mic back to Fahd. Thank you, Fahd.
Thank you, Mohammed, for introducing Professor Ahmed Al-Khani, and thank you, Professor Al-Khani, for this outstanding talk about trigeminal neuralgia and doing what we need to stop this pain. Now we move to the talk of the president of the Moroccan Society of Neurosurgery, Professor Hakim Khadar, and I will ask Professor Adil Milhawi to introduce him. Professor Milhawi is well known in Morocco and in Africa. He is an active professor in the WFNS Rabat Reference Center for Training of African Neurosurgeon, and he is a functional neurosurgeon and also radiosurgeon, one of the radiosurgeon in Morocco. Please, my dear friend, will you introduce Professor Hakim Khadar? Thank you.
Thank you, my dear Fahd. Good evening, everyone. It's my pleasure to join you in this very nice and beautiful session with two great speakers already, Professor Haris and Professor Al-Khani. And it's my pleasure to introduce our friend, Professor Lakhdar, who is now the president of the Moroccan Society of Neurosurgery. He's also head of the Department of Neurosurgery in Casablanca. And as a functional neurosurgeon, he had the privilege to be the pioneer in introducing DBS in Morocco for Parkinson's disease in 2007. So please, Professor Lakhdar, please, if you can give us the Moroccan experience, since you have been now leading this and following our activity in all the centers around the country. Thank you very much.
Thank you, Professor Malhawi. Thank you, Dr. Labadi and Dr. Dalkawi for all the effort you are doing for maintaining this activity. It's a pleasure for me to introduce and to speak about the Moroccan experience in deep brain stimulation. I will thank first my mentor, Professor Azhari, who allowed me to go to Bordeaux and Grenoble for a long period of training to develop these techniques in our country. And I also thank all the teams, the Moroccan teams who are involved in this surgery, and mainly the French and other teams who were involved in the beginning and who helped the Moroccan teams to develop this kind of surgery. Despite the quality of training the Moroccan teams realized in their career. Share. I will talk about DBS, but I will give only a brief view about the Moroccan experience and the results of the brief